Alright, welcome back for lesson 3.3, Hyperparathyroidism. This is the third lesson in our parathyroid section in Essentials of Endocrinology. So in order to understand hyperparathyroidism, we have to know a little bit about the physiology of parathyroid hormone. So when you think of PTH, think calcium. That's the primary job of PTH. PTH regulates serum calcium levels. When calcium levels are low, that's the stimulus for the parathyroid glands to secrete parathyroid hormone into the blood, which then has effects on end targets, which we'll talk about in a second. Phosphate levels are also regulated by PTH at the level of the renal tubules, as are vitamin D levels. PTH stimulates 1-alpha hydroxylase, which is an enzyme found in the renal cortex cells that lead to the production of active vitamin D. PTH also blocks phosphate reabsorption in the proximal convoluted tubule, which also has effects on the ionized fraction of calcium in the blood. So that's what you need to know about PTH. So what are the etiologies and the pathogenesis of hyperparathyroidism? So you can see here from our nice flow chart, there are three types: primary, secondary, and tertiary. Primary is the most common type of hyperparathyroidism. And if we break that down further, the most common cause of primary hyperparathyroidism is adenoma. So a benign adenoma in the parathyroid gland that is functional and secretes high levels of parathyroid hormone. You can also have hyperplasia, which isn't a neoplasm, but is an increase in the number of parathyroid cells, which then reasonably leads to an increase in the secretion of PTH. If we go a little further, some high-yield associations here. If you ever see, for example, a patient who comes in with bitemporal hemianopsia and also is complaining of PUD, and they have high calcium levels, you might want to think one of the multiple endocrine neoplasias, either MEN1 or MEN2A. Well, what I just described would be MEN1, but MEN2A also includes parathyroid tumors as part of that neoplastic syndrome. Or, in more times than not, you can have just idiopathic adenoma. Secondary hyperparathyroidism is due principally to chronic kidney disease. Patients who have chronic kidney disease have problems with their calcium and phosphate levels, and that leads to hyperparathyroidism. We'll talk about that in a second. Vitamin D deficiency is also a cause of secondary hyperparathyroidism. Tertiary hyperparathyroidism is from long-term secondary hyperparathyroidism that then, for reasons that are unknown, becomes irreversible. So let's talk about the pathogenesis of primary hyper-PTH. So the stimulus can be a variety of things, but as we just saw on the last page, it's mostly an adenoma. So adenoma leads to increased PTH, and then that has end effects on the target cells. So principally, increased osteoclast resorption. That's what you need to really think of. PTH stimulates the osteoclast in bone to break down the bone mineral and release calcium into the blood. Also, as I said, PTH leads to increased vitamin D production through stimulating the activity of 1-alpha hydroxylase in the renal cortex cells. Also, PTH leads to decreased renal phosphate reabsorption, which then frees up more of the total serum calcium to be part of the ionized fraction, which is what is which is the physiologically relevant parameter. All these things lead to increased serum calcium, which then leads to the signs and symptoms of hypercalcemia, which we'll talk about in the slide on clinical presentation. Secondary hyperparathyroidism is a little less clear, but really what happens is the kidney is not functioning. This leads to decreased vitamin D, because as we said, 1-alpha hydroxylase is produced in the renal cortex cells. Decreased vitamin D leads to decreased calcium reabsorption, as well as decreased phosphate reabsorption from the gut, and that's why we leading to decreased serum calcium. Also, we get an increase in serum phosphate because phosphate excretion in the kidney is impaired, and so we have increased levels of phosphate in the blood, which binds up serum calcium and decreases the ionized fraction, which is the one we care about. Both of these things then lead to decreased serum calcium, which is then the stimulus for increased PTH, and that's how we would get hyperparathyroidism there. So epidemiology, I'll let you read this on your own, but pretty much primary hyperparathyroidism is the most common form, and it's the most common cause of hypercalcemia in the outpatient setting. So if you ever see a patient with hypercalcemia, primary hyperparathyroidism is definitely something that should be on your differential. All right, let's now talk about the clinical presentation of hyperparathyroidism. So when someone has overt hyperparathyroidism, they present classically with stones, bones, groans, and psychiatric overtones, which is the mnemonic to help you remember the signs and symptoms of hypercalcemia. All of these things are related in some way, shape, or form to increased levels of calcium. But something to remember is that a lot of patients don't present with these classic signs, but rather are asymptomatic. And you pick up some high levels of calcium on maybe a routine blood panel, but they don't come to you looking the way we're describing here. So just something to keep in mind. But if you do see hypercalcemia, that's when you should start thinking about hyperparathyroidism in your differential. But let's go through each one of these. So stones. So what are you thinking here? I said calcium levels are high. What does that do to the kidney? Well, high calcium levels lead to the production of calcium stones, so nephrolithiasis, and also just deposition of calcium in the tissue, or nephrocalcinosis. What about bones? How do you think hyperparathyroidism relates to bones? Well, we said PTH stimulates osteoclast resorption, right? And so that's breaking down the bones. So it's not surprising then that people with hyperparathyroidism will have bone pain. Now, I want to point out this osteitis fibrosa cystica. This is a high-yield association with hyperparathyroidism. Another name for it is called a Brown tumor. It's pretty much a almost pathognomonic feature of hyperparathyroidism. It's a lesion in the bone under the periosteum. You see this kind of hollowed out formation here. On any one of your tests, step 1 or step 2 CK, you probably won't be asked to identify this, but if you see anything having to do with hyperparathyroidism, you want to be thinking osteitis fibrosa cystica if you see a radiograph. Groans. What are the groans? So these are myalgias, pancreatitis, PUD, gout, constipation. All of these, again, are downstream of high levels of calcium. Calcium stimulates pancreatic enzyme activity, which causes kind of autodigestion of the pancreas, which is effectively pancreatitis. PUD, because calcium leads to increased secretion of gastrin. Gout, because it can stimulate the deposition of uric acid. Constipation, because calcium is involved in the contraction of smooth muscle, so you get a higher smooth muscle tone, which can block the flow of fecal matter. And myalgias, because remember, calcium also causes skeletal muscle contraction, and so higher levels of calcium will stimulate that. And psychiatric overtones, that's just calcium causes badness in the brain. So we have things like depression, anxiety, and confusion. Diagnosis. So you should be thinking serum calcium levels, and don't forget to get ionized fraction because you need to take into account someone's albumin levels. Of course, a PTH assay, serum phosphate, urine cyclic AMP. Why am I highlighting urine cyclic AMP here? Well, because this is the kind of thing that step 1 or step 2 CK loves to test because it forces you to apply some basic science knowledge to a clinical problem. So if you recall from the basic science days, PTH is a hormone that signals through a second messenger, cyclic AMP. So PTH on its target cells, such as the renal cortex cells or through the osteoclasts, signals through cyclic AMP. And so you can actually see elevated levels of cyclic AMP in the urine, which can be diagnostic for hyper-PTH. Also, chloride to phosphorus ratio of greater than 33. You might not see this on your routine diagnostic tests, and maybe not even for hyper-PTH, but it's something to think about because you might see it on one of your board exams. Studies to order, radiographs, you'll see osteopenia due to the osteoclast breakdown of the bone and subperiosteal bone resorption. that is a characteristic feature of the kind of bone breakdown that we see with hyperparathyroidism. Let's talk treatment. Primary, secondary. We'll start with secondary because that one's a little easier to understand. Secondary, the problem is renal failure. If you could reverse renal failure, that'd be great. So that should be your primary task. But as kind of ancillary measures, you can give calcitriol, which is vitamin D2. You can give calcium, and you should also encourage dietary phosphate restriction. Now, what about for primary hyperparathyroidism? Well, the definitive treatment is surgery. If 85% of the cases of primary hyperparathyroidism are due to adenomas, you got to take the adenoma out. Otherwise, parathyroid hormone will just keep going up and causing badness. So, definitive treatment is surgical. But not everyone should go to the OR, especially if the patient is asymptomatic. And if the patient is symptomatic, then you should consider surgery unless they have some contraindication to that. But if the patient is asymptomatic, like so many of the patients who come in to the outpatient setting are, who have hyperparathyroidism, then you need to confer with the guidelines here on the side, which we'll explain in a second. Medical management includes fluids, which would induce calciuresis, and furosemide, which is a loop diuretic. Loop diuretics cause calcium excretion. Don't give thiazide diuretics. If you see someone who has hypercalcemia, definitely don't give thiazide diuretics because they cause increased calcium reabsorption. So parameters for to kind of guide you in whether a patient should have surgery. This is definitely high yield for your surgery shelf exam, or also for step 2 CK. So serum calcium should be 1 milligram per deciliter above the normal limits. Creatinine clearance should be less than 60 mils per minute. Bone density. So if they have low bone density from all that bone reabsorption, that's going to be reflected in a T-score less than 2.5. And if you see that at 3 sites, that's an indication for surgery. And also age, less than 50. A young person under 50 has a lot of life to live. And if the hyper-PTH goes unresolved, it can lead to some of the overt clinical presentation that we discussed a few slides back. So these are the things that would encourage you to send an asymptomatic patient in for surgery. So a summary, 3 types of hyperparathyroidism: primary, secondary, tertiary. It's the most common cause of hypercalcemia in the outpatient environment. So if you see hypercalcemia, definitely have hyperparathyroidism high on your differential. Think adenoma in 85% of the cases of primary hyperparathyroidism. Definitive treatment is surgery. Medical treatment for those who can't go to surgery, and for asymptomatic patients, refer to the guidelines. High-yield associations and buzzwords: osteitis, fibrosis cystica, MEN1 and 2A, and stones, bones, groans, and psychiatric overtones for your mnemonic for remembering the clinical presentation of hypercalcemia. All right, that's it, and we'll see you in the next section.